Hello.
Oh, good evening, Dr. Brito.
Good evening. How are you, sir?
How are you?
Yeah, I'm good, sir. Thank you. Thank you
Thank
for the invitation to make me the part of
you.
this event, sir.
Doctor, shall we make you co-host?
Yeah. Can I share my screen or?
I will make it to share the screen.
Yes.
Prashant, can you make him co-host? Dr. Prashant?
Yes, sir. One minute.
Dr. Brito. Then you can check the screen, share screening.
Yeah, let me check
The
now.
PowerPoint is moving or not. You are settled in Coimbatore only, or?
Yes, sir. Basically, I'm from Tirunelveli district,
No,
and I settled. Yeah, and then I settled in Coimbatore.
very good.
Is my slide, sir, visible?
Coming up. Can you make it in a slideshow mode?
Yeah. Now.
Yeah, it has just come. Can you make it? Yeah, it has come very nicely.
Yeah, it's changing, sir.
Yeah, it is changing nicely.
Yeah, sure, sir.
Thank you.
It's done. Yeah.
We'll start at 7 o'clock.
ബിനോക്കോളോട് പേര് കണ്ടിട്ടില്ല. പിന്നെ ഒന്നുമില്ല. അവനിപ്പോ ഇതുണ്ടല്ലോ, സ്റ്റേറ്റ് കൗൺസിലർ ആയിട്ടുണ്ട്.
Confirm.
Good evening, Dr. Arun Kumaran.
Sir, very good evening, sir. How are you, sir?
What's the time in Nigeria now?
2:30 here, sir, PM.
Afternoon, yeah, good.
Yeah, India is ahead of 4.5 hours, sir.
1 week spent now.
1 week's gone, 3 more to go.
How is the pharmacy practice setting there? So okay?
Yeah, they just started PharmD program here, sir. I'm just teaching them there. I'm attending their classes. In fact, I'm also taking class for them. It's going good, sir, here. How are you, sir?
Fine.
Brito has joined?
Yeah, Dr. Brito?
Brito?
Yes, sir, I have joined. How are you, sir?
Arun Kumaran.
Yeah, Brito, good evening.
Thank you, sir. Good evening.
How are you, Brito?
Yeah, I'm doing good, sir. How are you, sir?
Yeah, fine. And your guide called me before 1 week before.
Okay.
Sir, you got any information from the university regarding my student Brito's PhD Viva?
Okay.
Sometime I may get it. I'm just telling you.
Yeah, please
And
confirm it, sir.
if
I'm
I am
waiting
not
because
getting also my wishes to you always.
Oh, thank you. Thank you, sir. Thanks a lot. Because of
I
all your
will-
motivation and guidance, we are there here, sir.
No, you deserve it. I know. It's good. You can do it. If possible, I'll try to come and meet you there.
Yes, sir. Please, sir.
I'll be here for another 3 weeks.
Oh, great, sir. Learn the good things and you come and teach us, sir. That will helpful for
Oh,
us to
yes,
practice here.
of course. You are no more student. They are all matured, quite matured enough. You are teaching us now. You started
Yeah,
teaching us now.
and nothing like that, sir. We always used to be a student and to learn a lot of things from you, sir.
Thank you. God bless. God bless.
Thank you, sir.
My
Thanks a
teacher
lot,
is
sir.
there. My teacher is there, Dr. Jayasir sir. My
Then we
motivator,
must have
guide,
the
guru.
blessing from all the people.
Yes,
Thank you,
of course.
Arun Kumaran. Thank you, Dr. Brito. Shall we start now at 7 o'clock?
Yes, sir.
Yeah, we can.
Okay,
We can
good
start.
evening to everybody. Thank you for joining the refresher course on pharmacy practice. And today we have a wonderful session on a very important session as far as pharmacy practice is concerned, medication error and patient safety, how medication is important to patient safety. And we have a wonderful young dynamic clinical pharmacist from Ganga Medical College Hospital, Coimbatore. And to start the session, we have Dr. Ramya Gayatri, Dr. Andrea, and also Dr. Ansu. And may I request Dr. Ramya Gayatri, Assistant Professor of Pharmacy Practice, Chemist College of Pharmaceutical Sciences and Research, Ernakulam, to formally welcome the gathering and start the session. Over to Dr. Ramya Gayatri. Dr. Ramya?
Yes, sir.
Yeah, please.
Yes. Good evening, everyone. It gives me immense pleasure to welcome you all to this important webinar on medication error and patient safety, organized by Indian Pharmaceutical Association. Medication errors remain a major concern in healthcare, and continuous education and awareness is key to address them. Today's session is an excellent opportunity for all of us to deepen our understanding and renew our commitment towards patient safety. This webinar is a part of continuing series of knowledge update sessions designed to keep us informed, skilled, and prepared to meet the evolving demands of healthcare. First of all, I would like to warmly welcome our very dedicated leaders of IPA state program, that is Dr. Jayashekhar sir, Dr. John Joseph sir, and George sir to this program. Their vision and commitment have been instrumental in shaping programs like today's webinar. We are truly honored to have with us Dr. Britto Durai Singh, Head of Pharmacy Services, Genga Hospital, Coimbatore, a distinguished expert whose vast experience and insights will surely enrich our knowledge and practices. Welcome, sir. It's my pleasure to extend a warm welcome to our session moderator, Ms. Andrea Tom, Associate Professor, Pharmacy Practice Department, Nirmala College of Pharmacy, Muvattupuzha, whose dynamic leadership will guide us through today's insightful discussion. Welcome, Andrea, ma'am. I would also like to take this moment to specially acknowledge and appreciate the pillars behind our Train the Trainers initiative. There is Ansu, ma'am, Assistant Professor, Mar Dioscorus College of Pharmacy, Thiruvananthapuram, who is about to propose vote of thanks in this program. Dr. Suja Abraham, Dr. Manju, Dr. Shamna, and many more, whose dedication and tireless efforts continue to strengthen our learning journey. A special welcome to all of our participants for today's program. Your presence reflects our dedication and advancing healthcare quality and patient care. Let us actively engage, learn, and grow together during this session. Once again, a heartfelt welcome to each one of you. Thank you. And now I invite Ms. Andrea Tom to take over and guide us through today's proceedings. Over to Andrea, ma'am.
Thank you, Ramya madam. Thank you, Ramya madam. Thank you, Jayashekhar sir.
Thank you.
Good evening, one and all. Dear participants, as we are about to discuss about medication errors and patient safety, as discussed by Ramya madam, you all know that medication errors are a preventable cause of patient harm, but lot of advancements in healthcare has occurred, but we still strive to stop medication errors, especially in India. The best example happened in March 2025, I mean last month only in Kerala, in Kannur district, as the participants from Kerala may know about that. 8-month-old infant was given paracetamol syrup, paracetamol drops instead of paracetamol syrup by a community pharmacist, and due to high dose, the child was severely ill and got liver complications and admitted in a famous hospital ICU, and that was aired in all news channels that time, that means in March 2025. So incidents like this, of course, is an eye-opener, and this underscores the importance of a multifaceted approach in healthcare, especially fostering a culture of safety, continuous staff education, robust reporting system, and audit also. So it's crucial that we all join hands to protect patients from this preventable harm. At this juncture, IPA Kerala State, under the leadership of Dr. Jayashekhar sir, has organized a talk and refresher course on medication error and patient safety. It's very difficult to get a resource person with a clinical experience to give his talk about his expertise on medication error, especially from Indian clinical settings. But today, we are fortunate to have an eminent resource person who is well experienced to deliberate on this topic. As Ramya madam already discussed, we have with us Dr. L. Britto Durai Singh, who is currently working as the head of pharmacy services in Genga Hospital, Coimbatore. He has a vast experience, about 10 years in Indian clinical settings, and he's completed his bachelor's and master's from MGR University. After that, he is currently pursuing his PhD also. He started his clinical experience as a clinical pharmacist and assistant professor in PSD institutions. Thereafter, he shifted his job as head pharmacy divisions in Genga Medical Center. And now sir is having a lot of experience in his hospital. Today, I think he'll deliberate on the experiences from his hospital settings And he'll also talk about how we, as pharmacists, we can play key role in preventing medication error. So once again, I welcome Dr. L. Brito Singh
Okay.
to this
over to
session.
Dr. Brito, please.
Yes. Thank you so much, IPA Kerala State Branch, for inviting me as a resource person for today's event. And it is a great honor for me to share my experience to the pharmacy fraternity. And most of the time in the hospital setup, we used to talk to the doctors or the nurses. And the number of the proportion of classes to the pharmacists compared to the doctors and nurses are less in the hospital setup. I'm very happy to share that my experience to the pharmacy fraternity. And I especially thank Dr. Arun Kumaran and Dr. Jaishankar for giving me this opportunity. So today I'm talking about medication errors and patient safety. And in the interactive session itself, they have discussed in detail what happened in Kerala. So as we all know the importance of it. In today's, my slides are visible, sir?
Yeah. Your video is not on. It's no problem. Camera is not on.
Yeah. Let me put on.
Okay.
Yes. Now it's fine, sir. It will be always good to see the face when we are talking to the people. Yeah. Great. Thank you for that, sir. So in today's presentation, I'm going to just discuss about what is medication error. And predominantly we must understand medication error rather than to know the definition. So definition quite common. So the reason why I always choose to talk to the medication error, the one good pharmacist can prevent nearly 20 to 30% of the medication errors are happening inside the hospital. Because at one point of time in the medication practices happening in the hospital, it will flows on the hands of the pharmacist. Most of the time we are the person who will deal with the drugs, and only after we suggest, or only after we recommend, only after we dispense, only after we dilute, it will go to the patient side for the administration. So nearly 30% of the medication errors can be preventable when the pharmacists are good and smart. That's what I always used to tell. So today I'm just going to share the definition of medication error and common factors and different situations in the clinical setup, what we are experiencing as a clinical pharmacist, and when I am being as administrative pharmacy, what my experience on that, and how to categorize and prioritize the importance of medication practices into the area and risky areas, and what are all the strategies we can plan to prevent or avoid the errors in a clinical setup. As to the definition, I would say it's a preventable event, because the definition per se says that when the wrong medicines or the wrong practice of medicines happening under the controlled environment, which means when it prescribed by the quality and qualified physician, when it is administered by the qualified nurse, when it is dispensed by the qualified pharmacist, when all the qualified people are there, something is happening wrong to the patient because of the medicine, it's called as medication error. So medication error definition, it doesn't say that it happens somewhere in the community, some unqualified people are using, or illiterate people taking their own medicine. When in the controlled environment where we have the qualified physician prescribes, qualified pharmacist dispense, qualified nurse administers, qualified team monitors, when something goes wrong, that is called as medication error. That is what in the definition it has been very clearly given, like any preventable event. So medications errors are preventable because it's happening on the controlled environment where all the qualified people are dealing in each and any step on the practice of medications inside the hospitals. And when you look at the steps in the practice, you just assume as a patient, we'll go into the hospital, we do some laboratory testing or any radiological assessment, and we may get diagnosed. We go and meet a doctor prescribes the medicines in the prescription. We go to pharmacy will dispense, cross-check, educate and all the things. We'll go to the nurse will administer, we get well. When you look at each and every steps, there is a qualified person, there is a defined process and protocols to be followed. when any deviations occurs by any one of the qualified peoples, the errors happening. So definitely it might be avoidable. And always when you look in a clinical setup, we find in case of any errors occurred, I always look on the whole, what went wrong. And it includes a lot of people into it. And we must assess, we must do the root cause analysis. We must come with some proper preventive measures on that. When the process, whatever I have designed on the diagnosis, prescription writing, dispensing, administering, documenting, and all the things, that's the people. When it falls on the healthcare professionals, the predominant factors are the poor knowledge, or poor training, or the poor communication. These are all the three domains. When you avoid, again, the 50% of the errors can be minimized. See, for example, most of the hospitals in India or most of the pharmacies in India, we may have very junior peoples or be handling in the single, duty. Sometimes when the shift changes, we may have the junior pharmacists. When the shift changes or the night shift, the proportion of the nurses on the senior junior ratio differs. So they might not aware what for the drug has been given, how it to be used or diluted, or how the infusion rate to be fixed, what monitoring parameters to be seen, or the handing over, taking over. So I have given this drug, don't give that. I have given this prescription and I have dispensed the drug, don't give that. So, when the factors causing the errors from the healthcare professionals, their lack of knowledge, lack of training, and lack of communication. And other factors are they may be fatigue or overwork, the ratio of handling prescription, and then the pharmacists in the pharmacy are minimal, the pressure and all the things. That is negligible, that can be addressed by the team when we have a good team and we work very closely with the people. But the training, knowledge, communication, individual should develop, individual might have an idea. That is where the IPA is organizing this kind of program, making the pharmacists to get aware, get them trained, what went wrong, what's happening into that, what's new, and all the things. When it's happening from the patient side, so the healthcare professionals, knowledge, training, communication. Patient side, the complexity of the clinical status. When you have the patient with multiple comorbidities, which means that more diseases and more drugs, always it leads to the error. And environment, when you be in the pharmacy where you have a lot of distractions, patients are coming in, going out, shouting, you may have a lot of phone calls to attend, you need to answer to a lot of people, that time you need to do stock audit. When you have the pressurized institute, when you have more distractions, when you does not have the standard protocols, this is where the prescription to be received, this is where it has to be filled, this is how it has to be packed, this is how the patient should be educated, this is how the drug to be dispensed. When you did not have the standard protocols on the medication management practices inside your pharmacy, or when the pharmacy or the environment where we are using medication has a lot of distractions, it leads to medication errors. And the medicine per se, you may have a lot of look-alike, sound-alike medicines. The labels are stuck wrongly. You may heard it wrongly. A lot of things can happen from the medicine aspect. And then the task. So you may be allocated yourself for ordering, monitoring. When you are not following the task or the task is misplaced, and again it leads to error. And last, most of the pharmacies or most of the hospitals, we are getting into the digitalized mode. And for example, when you type one brand of paracetamol, for example, it is a disclaimer that I could not use the company's name, but for the example I'm using, if you write Dolo, you can get list of drugs, Dolo, Doloper, Dolonex, Dolovin, this, Dolo, lot of Dolo will come. What to choose? And what to be ordered, what to be dispensed. Again, this is all the questions. So before getting in detail about medication errors practices inside the hospital, I would like to make you to understand. So this is the prescription practices. Patients comes, diagnose, get the prescription, go to pharmacy, get the medicine, administered, and they will go or they will stay in a bar. And there are a lot of people involved into it, a lot of process involved in it. The first one is healthcare professionals, when we did not have the good knowledge, when we did not have the training, when we did not have the communication, leads to error. When the patients, when we have the critical patients having a lot of disease, lot of drug, error. Environment, more distractions, lack of standard protocol, error. Medicines, there are multiple brands for the same molecule, the same sound alike medicine, look alike medicine. When you have it in your pharmacy, error. When you did not have the properly assigned task, error. When you have more number of problems on your system, error. So this is the process. This is the factors where it all leads to the error at any point of the medication practices inside your pharmacy or inside your hospital when you work. And this is not the common thing. When the patient comes, doctor prescribe, error can happen, prescription error. Or when in the file, for the patient file or the hospital record, the doctor writes in the drug chart, it will be transcribed to the pharmacy by the nurse. So when they are rewriting on the drug order sheet from the file to the prescription, send it to the pharmacy, the error can happen. That's called as transcription error. Dispensing inside the pharmacy, the people like pharmacists like us, we may commit dispensing error. Once they got a medicine, patient go for the administration, they may give it wrongly or wrong patient, anything can happen, administration error. Documentation, they may do wrongly, documentation and monitoring. These are all the different types of error where it plays the prescription, transcription, dispensing, administration, documenting, monitoring phase. So this is the flow. I'm going to discuss in detail about different types of error with 1 or 2 case examples, what we are facing normally in your day-to-day practice. And prescription error, and everyone aware, even the government of India and medical council and all peoples are coming and stating that the prescription to be in capitals. But again, it would be very difficult, very difficult for them to have the good complaints on the practice. Especially when we are being in a community pharmacy, again, it would be the tough. When I'm having the prescription written from Kerala or Andhra Pradesh, or we have patients from all over India and a few patients from outside they are coming. If it is not digitally printed, it would be again difficult when I am going and seeing my patient and referring their old medicines and getting to know what it is prescribed. And sometimes, if at all we are having the doctor's informations or contact numbers, it would be easy for us to talk to the doctors and what has been prescribed. Again, it would be very difficult. So when the prescriptions are written wrongly, and that there are a lot of chances of error, and predominantly these prescription errors are common. When you look in the percentage wise, the prescriptions error can happen nearly 40 to 50% inside the hospital setup. When the right prescription is generated, nearly 50% of the errors can be avoided. So when you look at the different reasons or the natures of prescription errors, if it is like irrational or incorrect drug of choice. When you have the patient with diabetes, or we always avoid beta blocker, because it masks the warning signs. When you have the patient with cardiac disease, some kind of beta blocker we avoid because it leads to bradycardia. And this is all. When you choose the drug, whether the drug is needed for the patient, or whether this particular dose is okay for the patient. When you have the patient with renally competent, and based on their creatinine level, the dose to be adjusted, whether that has been done or what. When you are having the patient with the gram-positive infection, whether gram-positive coverage has been given or what. So this is the factor, when we do not give the right medicine or rational medicine to the patient, it leads to the error. Or under prescribing or over prescribing. When again, I'm coming to antibiotic, the particular frequency or particular dose or particular flow rate, when you are infusing, everything to be followed. When you did not complete the course of the antibiotic, error. When you are putting your patient on steroids, when it was not tapered, when you are planning to use for long term, and the same dose has been continued, error. Or when you are giving without adding the special information, or when you are putting your patient on warfarin, when you are putting your patient on methotrexate, when the special information has not been given, some errors happen, error. Or overprescribing, by the fear of infection, we will put the patient on antibiotic. Or adding dual antibiotic coverage with the same spectrum. Adding one another OHA when your patient is on controlled glycemic levels. And incomplete prescription. It is a predominant factor. When you look at the parts of the prescription, you can see most of the people are pharmacists attending this meeting. So See, when you look at the prescription, you just think that how many prescriptions are complete, which means the dose, duration, age, sex, date, and specific information, or everything has been written very clearly. It's very minimal. Even in the hospital, we are reaching only 80 to 85%, hardly. We are working very closely, and most of our prescriptions are written by the qualified people. Still, we could have the lapse in 15%, because it would be difficult for them to write the special information or write the duration specifically or write the dose correctly. They will write one tablet for injection 1 ml 2 cc. This is all the common problem. And ineligibility, it's a very common thing. And abbreviations, you must use only approved abbreviation by ISN. I could like to give an example. For example, we have the prescription to pharmacy of OD, thyroxine. OD in the sense once daily, that's the frequency. If they're writing OD of thyroxine and OD of alprazolam, think that OD of thyroxine to be given in the morning empty stomach. And OD of alprazolam predominantly we used to give at night because it's a safe pill. The OD to be avoided. And when your physicians are writing in the household measures, for example, Crimafin 2 teaspoons or Hemab syrup 2 teaspoons. And you just think yourself, how many of us are aware if the patients are giving us the prescription of 2 teaspoons, how much ml you will tell to the patient? See, this I have done an exclusive study in the hospital where I worked in 2 to 3 years back. And I could find nearly only 38% of the nurses are answered correctly. 1 teaspoon is equal to 5 ml. 2 teaspoons equal to 10 ml. I always advise or suggest and recommend my clinical team to write the dosage forms or the things very correctly in a ml. Or I always recommend them to use the numerical frequencies. Instead of writing OD, I would recommend them to write 100 or 0010 if the drug to be given at evening time, because certain antihistamines, if you are advising your patient for Montelukast, it might be taken in the evening time rather than at a night time. If you are writing 001, the patient will take at 10 o'clock. Most of the inflammatory parameters are very active in the evening time. So you should write at evening, or when you are giving some laxatives or diuretics. It should not be given in later night. It should be given in the daytime, because the frequency of urination get increased when you're putting your patient on Lasix in the evening time. These are the small things. When it's missed, error, the patient gets affected. And again, they will go, fall, come, a lot of things can be avoided when we look at the prescription very carefully, when we wanted to give the informations very carefully, when you collaborate with your patients, when you are making the clinical decisions. For example, in the hospital where I work, for some drug, we always advise or recommend the doctor to collaborate with the pharmacist and then the patients, so that every information should reach to the patient on time and they will be following all things. This is an example. I would say, my friends, you can look here the felotipine for Plendil and Isodil. It looks like, and see here, the doctor has written Isodil. Instead of that, we have given Plendil, and with a dose of 20 mg, it reached 60% overdose. And then, at end, what happened? The physician and pharmacist who involved in commission of these errors are punished with a penalty. It happened. In India, it will come. India, we are managing by collaborating with the doctors and pharmacists, with other people. But definitely, it's a punishable offense. Now the awareness are getting increased. Most of the people, even though we are giving the medicines, the doctors are prescribing, side of the pharmacy, they are sitting and they are Googling it. So it will come, the small thing, Plendil and Isodil. See the 60% of the overdose, and it end up with very harm. And transcription errors. I'm coming to it exclusively for a hospital setup, because for the community pharmacy, the patients may come with a prescription written by the doctor, or they'll come for the OTC practice. They'll come and tell you the problem and you may dispense the medicine. But inside the hospital, when the hospital is not completely digitalized, and mostly the prescriptions will be written by the doctors in the drug chart of the case sheet. The nurse, in the small transcription sheet, they will copy the orders, whatever the doctors have written in the prescription, they will transcribe it. I'll tell you a lot of examples. It will come very blindly. Give paracetamol 4. What the pharmacist will give? whether they will give tablet or injection or syrup or suppository, or they will ask injection Clexane 2. What dose we will give, whether to 20, 40, 60, 80. Sometimes I may have the prescription to my pharmacy, Piptas 2. What strength? It would be very difficult. Even when I'm having the very small pharmacist with my team, with a crowded pharmacy, he will decide by his own. Please do not do that. Check with your clinical team, check with your nursing team, ask their help. Make your hospital practice into the EMR so that the things, whatever you are receiving, it will be clear. And if it is digitalized, the time saving for the pharmacist is huge. When I'm having the wrong transcribed prescription to the pharmacy, and I may need one of my pharmacists to sit and call the nursing staff to get the dose confirmed, spelling confirmed, and all the things confirmed. Very difficult. So when we work on it, again, that 11 to 12% of the errors can be minimized, and predominantly the time of the pharmacist is saved. And sometimes what happened in the critical situation was they will write the prescription for one patient, they will stick the ID sticker for the another patient, and they will give it to the pharmacy. When the small pharmacist I'm having in a pharmacy, he will type the billing ID for the one another patient and calling one another patient. Crowd, fight, many things can be avoided. It's not only related to the patient, it saves you time. It avoids the confusion. There are a lot of things is benefited when you're making the system TMR. And dispensing error, I always request this pharmacy fraternity to spend at least 1 minute extra, 60 seconds extra when you have the multiple drug. For example, if your prescription has more than 5 drugs, please spend 1 minute extra. My kind request to the pharmacist, 1 minute. 1 minute, not by the single pharmacist, it by the unit. For example, when one pharmacist receives the prescription, call the name with the patient, whether the right patient prescription has been received. It takes nearly 2 to 3 seconds. Whether, for example, I'm going and giving the prescription to you, you can call, are you Brito? Yes, fine. Give it to them. It's confirmed. When the billing pharmacist, when they have any doubt related to the dose or the drug, confusing words, anything is missed, please seek for the help. Check with your nursing team. It may take nearly 20 seconds to 25 seconds. So first time you may take 2 to 3 seconds and 25 to 30 seconds. It becomes half minute. And once it's properly billed, when it goes to the filling section, their pharmacist, the third pharmacist will fill all the things on the tray and they'll come and keep it on the dispensing pharmacist. Again, you must spend at least 25 seconds to check, recheck. It covers nearly your 55 seconds. And then before you are giving to the medicine to the patient, again you cross check the name of the patients and please stop what and all the drugs to be taken how. It covers 60 seconds. The 1 minute rule, I request all the pharmacists to follow. When you receive the prescription, cross check the name of the patient, first check. When you are billing, you please check or double check with your clinical team or the nursing team, even the small doubt you have. Small doubt. When the cholecalciferol 60,000 international unit has been prescribed daily, don't put 6 tablets or 7 tablets in a week. Check with the doctor. Sir, it has to be given in a once weekly treatment. Should I give to the patient for daily? Did you know that? Did you aware that? Because one of the smallness you might be intending in the system when the doctor says, error can be avoided. When the pharmacist feels, don't always believe the next person, he kept everything nicely. Because there are a lot of strength difference, look-alike medicine, sound-alike medicine, everything is available. So when the pharmacist who responsibility for packing to do double check with 25 seconds, even though it processed on different pharmacists rightly. Before you are handing the pack to the patients, again you please check. Call the patient's name. Talk 2 to 5 seconds extra, but please take once weekly. Please drink plenty of water. Please do that. It will bring a lot of respect to the pharmacist. So dispensing error, it should not be acceptable when we have a very good pharmacy team in your center. But in spite of things it's happening, please accept your mistake. The recent, I work with 80 to 90 pharmacies, out of which nearly I'm having 50% of the pharmacists are having less than 1 year of experience. The recent trend, what I'm feeling is they are not, feel guilty, or they not feel more responsible. They just try to blame others. Do not have the blaming culture. Accept your mistake, learn from the experts, avoid the error. That brings a lot of respect to the pharmacy profession. And again, the case example, when your patient was on 5 mg of warfarin, coming to the pharmacy and they checked PTANR, everything was normal, but the pharmacist mistakenly given 2.5 mg of warfarin, the patient suffered with thromboembolic stroke. It would be very difficult. When you are dealing with a high-risk medicine, always I would request to have the high-risk medicines list which is available even if you are in a community pharmacy setup. When you deal with the community pharmacy setup or the hospital pharmacy setup with high-risk medicine, double check is mandatory with the independent pharmacists, not by the same pharmacist, with the independent pharmacists. Please check, because once once the drugs moved out of your hand, the patient is going to suffer a lot. Please do independent check for the high-risk medicines. And again, I told you sound alike medicines. There are a lot of brands in India, whoever writes or applying for an approval gets approved. I could name few things which is available: GABA, PIN, gabapentin, GABA, per, a lot of GABA. When you have the molecule of gabapentin, everything which starts with GABA. Always I would tell to my nursing team. Or when you have the prescription for Dolo, DOLO, we will give some drug. When you taken off the O, DOL, DOL, pharmacist will give some drug. When you taken off the L, DO, we will give some drug. When you simply write D also, we will give some drug. There are a lot of brands, even the small spelling mistake end up with a different molecule and different. There are a lot of look-alike, sound-alike medicine. Wherever you work, based on your previous experience. For example, what I gained the experience was I worked on the different look-alike, sound-alike medicine. Once I found from the patient side that patient are prescribed with Brigabalin of one brand, and my pharmacist has given clindamycin of one another brand. When I look at the capture, it looks very same. Again, I revised my look-alike, sound-alike list. Get the experience, report it, revise it, make them to aware of that. Your dispensing errors will be minimized. Again, look-alike, sound-alike. This is an example. 69 years old patient. Instead of Milrinone, it is a drug where we give it to the cardiology risk patient. They have given potassium chloride, developed tachycardia, shifted to ICU. Both are, highly risky drugs. When it is mismatched, we need to shift the patient to ICU. Think the cost of care, think the situation of the family. When the right pharmacist give the right drug, all the things can be avoided. The number of hospital days getting increased, cost of treatment getting increased, the patient suffers a lot, family suffers a lot. When the good pharmacists work on that, and everything is minimized. Administration error, again this place, one, the prescription error, the second top errors are administration errors. Because we are working with a crowd, different people with different, even your nursing staff ratio with your patient, the knowledge of the nursing staff, and everything is matters. So always for the administration, when you are having very good protocol with the good pharmacist. For example, when I am giving the zoledronic acid, it is a bisphosphonate to my patient, and I am the first person to educate my nurse. What do we do? The step 1, hydrate. Step 2, look for any events. Step 3, start the drug very slowly. Step 4. So we need to talk to them. And when you are giving linezolid infusion, educate the nurse or educate everyone how long it to be infused, and the flow rate. When you are giving your nurse to administer for the amphotericin B, which diluent to be used? They should not mix with sodium chloride. It must be mixed with 5% dextrose. The small thing. The pharmacists are the essential part to avoid all the errors right from the prescription to the documentation and monitoring. Whenever you are giving the drug, don't always think that I'm a small pharmacist, I can only dispense. No, call your nurse. When your amphotericin B prescription did not have 5% dextrose, you must be alert your nurse and tell her that it must be only mixed with 5% dextrose. It is highly incompatible with other fluids. When you are giving linezolid to your nurse, advise them it must be infused very slowly. It should not be rapidly infused. it should infuse not less than 2 to 2.5 hours. If you're going for 600 mg, and protect, it is a photosensitive drug. Do not remove the car. It will be linezolid when you are going back to your hospital. Look, always it will be coming with a brown cover sheet. It will come in a cover. It should not be removed. It must be infused through that. And sometimes even you need to cover your IV set with papers, aluminum foil papers. You must advise when you need to have the good potency. And from the nursing side, the right patient, the right drug, the right dose, right route, and everything, it is the responsibility of the nurse to monitor. But on the administration, the pharmacist role is also equally important. What to be followed when you are giving the good protocol, you must assess for the adherence of your protocol, how effectively your nursing team is following that. Again, hypokalemia, admitted patient, the hospital team advised for the sodium polystyrene via rectal administration. The nurse has given in the Foley catheter. Problem, end up with cystitis as per the urology opinion. It could be avoided when you educated your team. When you wanted to go with the fluid therapy, I advised you how to be diluted, what type of fluid it must be diluted, how long hours it has to be infused, how to watch for the infusion related reaction, and what are all the monitoring to be done. All the things are matters. Again, actually, when you have the cascade with the sodium bicarbonate and potassium chloride, you should not keep it each other because it will come in a bottle. Instead of that, they will take that, patient is gone. Error. Once you have committed an error, we cannot get back all the things. And documenting error, it is three vertical. When the physician did not document the history, did not reconciliated the drugs properly, documentation is very vital role when in terms of drugs. I tell you an example, my friends. When the patient comes, see, I'm working in the very big trauma care center in Asia, and we have a lot of patients attending to casualty with multiple comorbidities with multiple drugs. Who is responsible for reconciliating the medication? Medication reconciliation is nothing but documenting or making the right drug list of what patient is taking. And then it is essential at the time of admission, there is a documentation on the drug. At the time of transfers, or each patient can, from the ward to ICU or to the theater or coming back to ward, what has been advised, what drug to be stopped, what drug to be restarted, essential documentation. And exclusively on cross consultation. When you ask your patient to get the cardiologist opinion, pulmonologist opinion, pediatrics opinion, they will advise something. How it's effectively reconciliated on the drug chart, how effectively it has been practiced. And finally, when the patient gets discharged. I'll tell you, when the patient gets admitted with the diabetes for some surgery, when the glycemic levels are high, always we stop the OHAs, oral hypoglycemic drugs, and we'll put the patient on insulin. When the patient will come for the high-risk cardiovascular disease, admitting for different procedure, the patient may be on warfarin or clopidogrel, dual triple antiplatelets. It must be stopped when we are taking the patient for the procedure. But once everything is done, it does not mean that the patient should be on insulin lifelong or the cardiac medications to be stopped. Again, it has to be relooked and documented rightly, reconciliated rightly, educated rightly before we are sending the patient to home. Documentation in each and every step, from the physician perspective, pharmacy perspective, nurse's perspective, is essential. When it comes to the pharmacist, it always ideal, it always necessary, making them to educate with the proper instruction and to talk to them about the drug interaction, document about the allergic details. So educate about the allergic detail. When you are in a community pharmacy or a hospital pharmacy, the patient will come and return the medicines to you. Talk to them what went wrong. When something is happened, document it. Alert it. Or you can give the systemized alert to them. Educate them. So when you are doing all the things, one step extra, our profession will be recognized and a lot of errors can be avoided. Again, the patients admitted in ICU with some pulmonary embolism started azithromycin, heparin, and it is not stopped when the patient shifted to ward. It is not properly reconciliated or the drugs are not properly overlooked and it was continued. Again, the patient had the hemorrhagic episode, blood transfusion, length of stay, and everything had happened. And when the right pharmacist look at it, when it stopped on the right time, this all the errors are minimized and it is avoided, And most of the time, some drugs require specific monitoring. Exclusively these drugs, list of drugs. I'll give you one example of that. When you are putting your patient on anti-tuberculosis medicines, monitoring liver function test baseline is essential. Advise your clinician to monitor baseline LFT before initiating this. When you are putting your patient on diuretics, ask them to monitor electrolytes in between. When you are putting your patient on warfarin, PTINR, it's essential so that the dose is minimized because the therapeutic range to be a time. It is the part of the pharmacist's duty to look at all the things before initiation, during the treatment, and after the treatment. And again, the patient put on trazodone for benign prostatic hypertension. They have some urinary problem, bladder, it was not emptying the urine properly. The patient was put on trazodone at bedtime. It was not properly educated to the patient. The patient had taken it on 11 a.m. and in between, with the urge of urine, he stood up and he fall down, admitted again. The small thing, when you are putting the alpha blocker to the elderly patient at night time, you should always advise, they should not get up suddenly. It can cause orthostatic hypotension. When they suddenly get up, they may have the shivering and they may fall down. You must advise them to open their eyes and strike for 2 to 3 seconds or 2 to 1 minute, at least 1 minute. They can sit for next 1 minute. The third minute they can walk. It will avoid all the errors. You need to educate the patient about the drugs. It will get avoided. And when we are looking for the special situations, there are two people are highly vulnerable. One is pediatrics, then the second one is geriatrics. Pediatrics, in the opening session, Madam has explained very clearly about the dose of paracetamol, what had happened, how it to be measured, how it to be given. For example, when you wanted to have a dry syrup, if amoxicillin clavulanic acid, up to the mark, the warm water to be mixed, it should be shaken well. The exact amount to be taken and it has to be given to store in the fridge. It should not be used for a week. Everything to be advised because pediatric patients are highly vulnerable on the dosing aspects and dose calculation. And for example, if you look at the pediatric syrup, it's available in 120 mg per 5 ml and 250 mg per 5 ml. If you look at some cephalexin syrup, 125 mg per 5 ml, 250 mg per 5 ml. So sometimes the clinical team can have the confusion. When you look at the common brand of amoxicillin clavulanic acid, Augmentin, you can see Augmentin Dio, it has the different strength and different concentrations per 5 ml. Everything to be notified to the doctor because if they are writing amoxicillin clavulanic acid syrup, you must know what to be given to the patient according to the age. If it is drops or the syrup, if it is the syrup in 5 ml, how much concentration? Everything to be clarified by the pharmacist with the prescriber before you are dispensing the drug to the pediatrics because it causes a lot of problem. And once it happened, it is not rewarded because we all have a children. When something happened to my child, it is not easy for me to accept. But the prescriber or the dispenser might not feel the same what I felt. Okay, it's a problem. The good pharmacist can avoid all the things. And when you go for the geriatric patient, when you look at the geriatric patient, they have different disease, different drug, their organs will function differently. Sometimes it may, digest, it may not digest. Since the prescribed drug has the interaction with some other drug, everything to be assessed. So there is a lot of role of pharmacist on pediatric and geriatric prescription. And whenever you go for geriatric prescription, you please think that they are the second pediatrics. They know something, they may not know something, they may forget something. Always write, make them to understand, reduce the number of pills, give them the combination, go with the different methods in the strip packing or making them to take different blocks of morning, evening, night, weekly, and big stickers with big capital letters. Use some techniques to avoid the medication errors when in terms of geriatrics. Or always tell them associated with their, if at all you are giving the weekly medicine, tell them that they will go for, Sai Baba temple on every Thursday. Tell them that every Thursday before you go in for Sai Baba temple, take this pill. They remember. Always don't push them to make them to understand this is the medicine, that is the medicine. No, they tend to forget all the things. Always, we pharmacists should understand the patient knowledge and then the nature before we are giving the information about the drugs. And for geriatrics and pediatrics, we must give a lot of time to make them to understand of the good compliance to prevent all the errors. And there are a list of high-risk medicines available in ISMP. Not all the medicines. Not all the medicines we need to spend a lot of time. My dear friends, I would recommend, for paracetamol for the adolescent patient, we no need to spend a lot of time. But for the pediatric and geriatric, it is dangerous. That is what. Not if you tell in your pharmacy, you may have nearly 500 to 600 brands. The bigger hospital, we may have nearly 2,000 to 3,000 brands. Out of which we must have the list of high-risk medications. Whenever we are dealing with high-risk medications, we need to spend a little more time extra on the prescription. And if at all you need to have any clarification, without clarity, please do not dispense medicine. Or if you feel that nurse must be educated because it is going to the general ward, please call and educate them. Whenever you are giving albumin, whenever you are giving 3% sodium chloride, whenever you are giving amphotericin B, please educate them. You should not feel the nurses are aware of all the things. Tell one or two informations to them that the whole errors is prevented. So my kind request, have the high alert medicines. And mostly we feel high alert medicines are NRX, alprazolam, this and that. There are a lot of things will be there in a pharmacy. Look at it. These slides may help you to pick up few of high risk medicine which may be available in a pharmacy. That should have the extra look when you are dealing or handling those kind of drugs. Those drugs, I always suggest, please have the regular check on it. For example, tapentadol, tramadol, or warfarin, or some diabetic medicines. When you have in a different strength, if you have MV, MV1, MV2, or GM1, GM2, when you have SR, plain XR, the same brand will be available in different strength. Those things you always allocate the pharmacist to do the daily stock out. So that when you pick it up, you can call the patient and you can tell them, okay, this and all the list of patients where I have dispensed this. So these drugs can be mismatched to them. Cross-check, call the patients, instruct them that I have dispensed you wrongly. Clear it, their error is avoided. Instead of that, don't put your mind on managing those things as a pharmacist. So that is my kind request to you. And to avoid all the strategies, inside the hospital, we may have the staff nurse or the staff pharmacist who exclusively to work on the medication practices. For example, when I am having the clinical pharmacist of the particular unit, the job for the pharmacist is to look only for the medication management practices for the particular house. He should not spend any time for any talking, chatting, this and that, lunch. No. At the time of administration, he must be there. And I have given the list of drugs to be monitored. I requested my nursing team to have the medication safety nurse to look only on the practice of medications at the time. So all the things to be looked very, very carefully so that all your errors and things got avoided. Inside the pharmacy, have a proper list, you educate your staff, train your staff, have a good regular stocking, and you have a stepwise protocol to be looked, taken, dispensed, everything to be in the right so that the errors can be minimized and the patient safety is ensured at the end of the day. Thank you so much for the opportunity, IPA Kerala State Branch, and I hope my presentation is useful for you.
Okay, Dr. Andrea.
Thank you, sir. Thank you, sir, for the wonderful presentation. like starting from different examples like antihistamine, Montelukast, diuretics, and you ended up with reconstitution of amphotericin, linezolid, lot of examples. So you discussed with from your experience. So participants, if you have any doubts or questions, you can ask sir now.
Yes, you can unmute and ask questions or put in the chat box.
When I look into the chat box, I can see Vinod Kumar corrected me like Kannur incident, which I discussed. Medicine was dispensed by the owner, not by the community pharmacist.
Yes, yes.
Thanks, Vinod, for the correction. Actually, so the owner was responsible for the incident. That is what he mentioned. So how can we prevent incidents like this, sir?
It's always to do double check, as like I mentioned, ma'am. If at all we have any doubt, we must call the prescriber, and that protocol to be there. We should avoid. I did not know completely about the incident, what happened, but whoever reaches us, and we everything. See in your chat box, the answer is there. The prescription must be handled by the qualified pharmacist. When we have the qualified pharmacist into the place, and all the errors like this is minimized, because at least he studied. He may have the doubt for the babies, instead of syrup, we must go only with the drops. He could have contacted the clinician to correct it, and all the errors could be avoided that time. So the qualified person to be there, and we must have the standard protocol in each and every places. That avoids a lot of errors.
Any queries or any explanation to be given, please interact with the speaker.
You can feel free to ask me question. I'm not that tough to answer. Please, there are two things when I'm giving a talk. If it is completely understood, there may not be any question. Or if nothing understood, there may not be any question. I feel that audience are understood completely to avoid the question. But still, if you have any clinical examples in your center to be clarified, I'm okay to accept your question to answer. So please get back to me if you have any questions.
Or you can share your experience also in medication error.
Yeah.
That will be more as participants, if you can share some experiences from your side, community pharmacy or hospital side, sir will also interact.
Participants are like students only, they're not asking questions.
Mm-hmm.
Dr. Britto's excellent presentation. You covered most of the subjects, and we are much thankful. And on behalf of IPA, I especially thank you, Dr. Britto, and also Arul Kumaran for their joining and enriching our community pharmacists and students of pharmacy in Kerala. And may I request Ansu Sara, Assistant Professor of Pharmacy Practice, Maharashtra College of Pharmacy, Trivandrum, to propose vote of thanks on behalf of IPA. Any questions are there in the chat box? Andrea, madam?
Yeah, I can see one or two questions. I'll just see through that, sir. A patient has been administered an esmolol injection instead of esomeprazole injection. One example is given by Gokul, I think, Gokul. He is saying he had one incident when esomeprazole injection has to be prescribed, was supposed to be prescribed, but instead of esomeprazole, esmolol was prescribed, was administered to the patient. Prescription was esomeprazole injection, but patient was administered with esmolol injection.
One is proton pump inhibitor, other one is esmolol.
And the next
Instead
question
of
I see
proton pump
was
inhibitor, patient was administered with beta blocker.
Yeah. It's a great, it damages the whole scenario.
It's a very important. Double checking is very important. Therefore,
Important.
not the same person, should be another pharmacist to check
Yes.
it. That's the usual protocol to be followed. But such mistakes can be avoided. And
So
this
somebody is asking, like, what are the general frequencies of giving amoxicillin clavulanic acid?
So it depends on the situation of the clinical patient. Mostly, sometimes we go with even 1.2 gram 3 times a day when we have the patient with maxillofacial injuries. So it is advisable for us, and 625 TID. So TID would be advisable, I feel, rather than twice daily for the patients. And again, the general frequency depends on the clinical situation. So in the high risk cases, mostly we go with 1.2 gram of amoxicillin clavulanic acid 3 times a day. And again, for the pediatric patients, it's weight-based. Please look at your chart. It will be given very clearly. For example, 20 to 30 mg per kg per day, and calculate it and advise. So better, I would suggest 3 times a day rather than twice daily.
Yeah, that's good. Any more questions?
No other questions, sir.
No, I have a question. Brito?
Yeah. Guru,
Yes, sir.
Yeah, I thoroughly enjoyed your presentation. Really excellent.
Thank you, sir.
And the
Thank
thing
you.
is, as usual, actually. And Brito, actually, while dispensing cotrimoxazole tablet to a patient, are we supposed to inform them or educate them to take plenty of water? What could be the reason?
I'm not sure exactly, sir. The plenty of water on cotrimoxazole, it could be the alkalization thing, or I'm not sure
Maybe.
exactly, sir. Yeah.
Oh, that's what I was told by somebody. I wanted to confirm with you since you are in clinical setup, right? Is it so or not? Anyway, I will not.
Usually, sulfamethoxazole present in it, it will not be that much soluble. It's not that much soluble. Therefore, if you have to take more water, it goes along. As you suggested, alkalinizers is, but usually it's not required.
Yeah,
those
that means
Septran 40 is taken about is having about 800 milligram or 400 milligram of sulfamethoxazole. So plenty of
yes,
water.
sir. 1 is to 5, no, sir.
Yeah. If it is some impairments are there, it's better to take more water. Dysuria can be prevented.
Okay. Excellent, Brito. Thank you. God bless. Thank you, sir.
Thank you.
Yes,
More
sir.
questions are there, Jaishankar, sir. One
Some more
person,
questions.
Vinod Kumar.
Brito, now our participants are more interested to ask questions.
Yeah, but it's a starting trouble, I feel.
Yeah, that's correct. There is a question from Vinod, Mr. Vinod.
Mr. Vinod is asking, like, in his hospital, I think government hospital only, I think.
Yeah.
So he discussed, like, the pediatricians there tell the patients to break oseltamivir capsule for pediatric patients.
No.
Like capsules oseltamivir 75 milligram, they'll tell to break the capsule, dissolve it in water and have it.
No. Please use the syrup, because oseltamivir syrup is available. Better we can calculate the dose and we can make them use rather than breaking the capsule, because
I think in government sector syrup may not be available, Jaishankar, sir, right?
Yes. Government sector, what is available, we have to, but pharmacy has to use it. That's a headache. There is no choice. But
it again depends. Yeah, but we don't know the clinical effect when you are breaking the capsules and we are giving, sir.
Yes.
Very rarely we used to advise in the private
if it
practices.
Is enteric coated, or if a tablet like enteric coated or sustained release, that should not be broken.
Yeah,
right,
exactly.
sir?
Right.
But this
very
capsule
right,
also maybe is it the Spansules? Is it Spansules type of capsule? I don't remember.
No, sir.
The simple plain drug only.
Plain capsule, yeah.
Then it can be done. There's not very much problem. It should be
that is what I also think.
It should be done quickly. Don't keep it for a long time to have some hydrolysis or some other effect. You should put
it should not be kept for long
time. Immediately dissolve in water and take it.
But I always suggest that when we have the alternative formulation,
sure,
this kind of things to be avoided. Yeah.
Yes, surely. That's the first preference.
It's like problem is like in government setup, they'll not make it available. Once the requests come, like after 1 year only, if the Indian comes, then only they will allow it. Otherwise, it will not be available in government hospitals.
But the therapeutic outcome, it's a questionable when we break all the things when we are using that.
There is one more question from
one participant discussed about one example, like doxorubicin had been administered instead of doxycycline.
അഭിനന്ദനങ്ങൾ.
Yeah, transcription
അതല്ല,
error by the
എന്താ
nurse.
പറയാ അയാള്?
They are sharing their experience.
കൊടുക്കാൻ പാടില്ല. നമ്മളോട്
there's again double checking is required.
Yeah.
Any more question?
No more questions, sir. I think Mr. Vinod is clear about the answer given by sir, right? About oseltamivir, right?
So you can unmute and discuss. Okay, he says no capsules available there.
That is what we also discussed. No, he was telling like capsule only dispense. If he can unmute and speak, that will be better rather than writing, because we are not sure what he's asking.
Vinod, can you talk, Mr. Vinod? Maybe he may be traveling. I don't know. Mr. Vinod?
Okay, sir.
Yeah,
Sir, I am in a train. I don't know how I can be audible.
let's see, you are audible now.
Okay, sir. It is a general practice by the pediatrics in health service. I have raised the issue, but they are not accepting it. They usually say that 75 milligram capsule is only that product is in the EDL list. So they
That is what we also
usually-
discussed. It is not available in the essential drug list of government hospital. That is why they are doing it like that, right? Next time you can
Okay.
intend it from
Even though-
KMCL, right?
Even though, madam, it is not available.
It's oseltamivir syrup is not available, no?
It's available in the market, but KMCL has to purchase it. It has to be included in the essential medicines list to be purchased.
No. It is not there. It is not the syrup is not there in the essential drug list.
That
But it is available in the market, sir.
Yeah, you can make a recommendation to the pediatrician to make such a recommendation. Let it go to higher level, and government will purchase it, because you can.
So it will be better.
Yeah. Because whatever.
Okay, sir. If the IP
find out the, you can point out the problem of stability of the solution, the drug when you put in water, and those differences will come. Therefore, it's always better
Okay.
to have it administered. Therefore, you make a note and give to pediatrician and let it go through DHS, and it can be taken care. That's a way. That's
okay, I will share
you should have an active role. Pharmacists should have an active
Sir,
role.
I will share some of the prescriptions with you.
Yeah, sure. Okay, thank you very much. Yeah, there is one more question, Dr. Andrea from Lakshmi.
Okay. I will, sir. Okay, sir.
There is one more question from.
Okay, sir. Thank you.
Thank you, Lakshmi.
Thank you.
She is telling she also got the same issue with oseltamivir.
Yeah.
Then she had
From the
added to
pharmacy.
mix with the
This
honey.
is the honey and this.
Yeah.
Mix it with honey and give.
No. See, I would comment on
Problem,
this.
Dr.
Always-
Peter, dose may change also. We will not be able to
Yes,
take correctly
exactly.
half or 1/4 of that.
Yes.
So,
When you break that, exactly that point, that when you mix with some
it's a potent
cruise,
drug. It's a potent drug.
So
And
I
then,
think this happens in many government hospitals, especially when the viral infections are high now in Kerala, no? Maybe they want to write oseltamivir. So in that case, the pharmacists can tell that particular doctors, and they can initiate that and inform the KMCL people to include that, I think.
Generally, our importance of pharmacist role comes in procurement also. That's important. Thank you. Thank you, Vinod, for bringing those things. Any more
Okay,
questions?
thank you, sir. It is not easy, sir. There is a committee.
It may take time, no? But let us start from government hospitals. Right?
Okay.
Meet the DM, your medical officer there, or the superintendent there, and then let it through the pharmacy. Let it go a recommendation, and then it goes to the, then it is a validated point. There can be a medication error due to these things. A patient will make this is a potent drug like that, like something you have to make it. Okay. Then it is, we are not simply dispensers. We should say that the importance of these things. Pharmaceutical care concept is to be important.
Okay, sir.
Okay, thank you. Then any more questions? Andrea, shall
No more questions. No more questions, sir.
Thank you very much. And now shall I request Ansu Sara, madam, Assistant Professor of Pharmacy Practice, Mardiasus College of Pharmacy, to propose vote of thanks on behalf of IPA.
Thank you, sir. Good evening, all. It gives me immense pleasure to give away vote of thanks to all participants, speaker and organizers for making this virtual refresher course on medication error and patient safety a success. Thank you to the organizers, IPA Kerala State Branch Pharmacy Practice Forum and our President Dr. J. Shekhar sir for putting together this informative virtual refresher course. Your efforts are truly appreciated. Special thanks to our esteemed speaker, Dr. L. Brito Duresing, for sharing valuable insights and expertise. Your contributions will undoubtedly enhance our understanding and practice. Next, I express my sincere gratitude to Mrs. Ramya Gayatri and Mrs. Andrea for their dedication and valuable contribution. I would also like to mention distinguished personalities of Pharmacy Practice Forum, Shamna Madam, Kiran Sir, Manju Madam, Narmada Madam, and Arun Sir for supporting this refresher course. Last but not least, I would like to thank all participants for joining. We appreciate your engagement and interest. Your participation made the session valuable. Once again, I thank all of you. Grateful for the opportunity to learn and grow. Thank you. Good night.
Thank you, Mr. Sir. Okay, thank you very much, Dr. Brito. Thank you very much, and namaste.
Thank you, Brito.
Thank you, sir. Thanks a lot, sir. Thank you.
Thank you,
Thank you, sir.
Thank you, Ramya Gayatri,
Thank you.
Andrea, as well as Ansu, and all participants.
Okay.
Good night.
Thank you, sir. Good night.
We'll meet again next month for another topic.
Okay, sir.
Thank
Okay,
you. Good night, everybody.
Okay.